Hello, I'm Dr. Jayne Morgan. I'm on the board of the Medical Association of Atlanta, and welcome to our first ever recording on menopause. But this won't be the last one. In fact, we're going to have others. This will be a series. So please join in. I hope you enjoyed this first one. You learn quite a lot, and then come back to see what we do in parts two and parts three. We have such an excellent specialist and knowledge expert in this area today. And we are so lucky to have her. Not only is she with us at the Medical Association of Atlanta, but we get to share her with you. Dr. Sandra Reed. Dr. Reed, thank you so much for joining us today. It's really our pleasure.
Thank you, Dr. Morgan, and thanks for the introduction. Just a little bit of my background. I graduated from medical school at the Medical College of Georgia. I'm a lifelong citizen of Georgia and practiced for 25 years in the rural community in South Georgia, where I did general OBGYN. I always had a focus on menopause throughout my career, and naturally, as I grew up and aged with my patients, I have had an even bigger interest in menopause as I approached that part of my life and transitioned as well. I now am on faculty at the Emory University School of Medicine, where I am an assistant professor and do just gynecology with a focus on menopause and perimenopause, and see patients there actively and treat them for this variety of issues that are associated with this transition. So thank you for having me today, and I look forward to a discussion on the transition.
Outstanding. Let's jump right into it. Such a robust discussion with someone who is practicing in this area. And as we know, so few doctors are practicing. We're still learning about this. And so, what you learn from Dr. Reed today may arm you actually with more information than your physician currently. So, just know we are on the cutting edge, and it is really our pleasure to have Dr. Reed with us today. You know what? I thought we would start with something really basic, but so easily misunderstood. Let's talk about menopause and perimenopause. Perimenopause is different from menopause. So maybe you could talk to us about exactly what is perimenopause and how do we know if we're in it or not?
Perimenopause is that period in a woman's life where she undergoes a menopausal transition. And this basically just by definition means around menopause. And it refers to the time that the body naturally transitions into menopause, which by definition is 12 months without a menstrual cycle. As far as the ages of women when they can start having symptoms of menopause or perimenopause, this can occur early in your 40s. It is unusual to have symptoms in your 30s, but there are some conditions that actually women will have symptoms in their mid to late 30s. But it's more common in the early to mid 40s, transitioning on into the late 40s. The best indication of when you're going to start having symptoms is when your mother had symptoms and started transitioning into menopause. And if your mother, God forbid, is no longer around, a sister would be your next closest person to ask what their transition was like. And perimenopause is that transition where your estrogen levels start to decline. They actually are only as good as the day that we draw blood and look at your estrogen levels, because they do fluctuate. But you tend to have larger fluctuations during perimenopause. And you may notice that right before you start your cycle, you start having some night sweats and a little bit more irritable sleeping. Those are some of the first signs that you may be transitioning into this perimenopausal state. Your periods may start to become more and more irregular. And you may notice a little bit of vaginal dryness as well. Mood swings can become more dramatic during that transitional period because of the hormone fluctuations. They come and go. And you can have some problems with the vagina and lose your lubrication and elasticity. Some women have problems with painful intercourse during this period of time. And you can actually lose the tone of the muscles in the vaginal area, which can affect your bladder and cause a little bit more incontinence. And this is also the time when you have decreasing fertility. So if you've delayed motherhood, this can be a challenging time as your hormones fluctuate to become pregnant if that's your desire. Doesn't mean you cannot have a child in your 40s. We see patients every day who have delayed childbirth and do very well, but it can be more of a challenge in some patients. As I said before, intimacy can become a problem as you experience more vaginal dryness. Excuse me. And this will transition and carry on throughout the perimenopause and menopause.
Dr. Reed, thank you so much for that. So, if I were to just sum it up for our audience, perimenopause is sort of that time 10 to 15 years prior to menopause. Menopause being when you've gone for 12 months without a menstrual cycle. That's the definition of menopause. And then perimenopause can start 10 to 15 years before that. And if you listen to what Dr. Reed is saying, you can be in perimenopause and also still be ovulating. So that's the beauty of the woman's body. We can be in perimenopause and still need to take birth control if we're trying to prevent pregnancy, or we can still become pregnant while you are in perimenopause. And then those are the symptoms of perimenopause. What about some of these unusual symptoms, Dr. Reed? So, for instance, for me, I had itchy ears. I started to have vertigo. I had palpitations. That could send me to 3 different doctors with 3 different workups, and nobody pulls it all together to say, "Hey, could it
Yeah.
be that you're in perimenopause?" So I saw a neurologist for my vertigo. I went to a cardiologist, had a big workup for palpitations. Nobody could find out anything. And I was a doctor and didn't
Yeah.
even understand. And Dr. Reed, as you know, as a physician, one of the tenets that we are taught in medical school is if a patient comes to you with a lot of different symptoms, it's probably not a lot of different things. It's probably
Right.
one thing, and we need to figure out what that syndrome is. So maybe we could talk about some of those lesser known symptoms of which I certainly suffered.
So, vertigo is actually a symptom that can occur during menopause. And because of the decline of your estrogen during that transitional period, it affects the part of the brain that controls balance and spatial orientation. And this can lead to dizziness and vertigo, which can also lead to anxiety and with the dizziness. We recommend that you take plenty of water, eat smaller meals during the day, limit foods with high sugar or salt, and avoid processed foods. And if you are smoking, we recommend that you quit smoking and limit your caffeine and alcohol intake. All of these can affect the vertigo and the dizziness.
Mhm.
One of the other things that we don't really think about that's unusual that can occur during that perimenopausal period is joints. Joints can be
That's
affected.
right. Frozen shoulder, aching joints.
Right. And it's also, that's because our joints have estrogen receptors in them, and
I
it
am so
helps.
glad you brought that up. So that is such a good point. Estrogen is not just all about our reproductive hormones. We have estrogen
Yeah.
receptors all over the body, especially as women. And so as those estrogen levels decline, as Dr. Reed is about to explain, you actually can have all of these other symptoms that have nothing to do with your breast, your uterus, your vagina. And so therefore you go to see a doctor and nobody knows what's happening, but you can get frozen shoulder and aching hips and knees and all kinds of symptoms and be in perimenopause and not really know it.
Yeah, and these symptoms are more common in women from 40 to 60 years old,
Mhm.
especially the frozen shoulder. And while there's no direct link between menopause and frozen shoulders, because we do have estrogen receptors all over our bodies, as our estrogen decreases, we lose the estrogen. And the way that affects the joint is it causes the tissue to have decreased elasticity and integrity, and just makes our joints more stiff. And this
Mhm.
can affect your knees, your shoulders, and some of the things that you can do to help with that is physical therapy, steroid injections,
Pilates is good. Those
Pilates,
types of
non-steroidal, like
Mhm.
Advil and Aleve. And then there are some procedures that require more of a specialist approach.
Right. Let's
Now,
talk
let's
about
talk about the itchy ears.
yeah, we
Okay.
can certainly talk about the itchy ears and all the dry skin and all of the things that happen that I know all about
Exactly.
now because I have a special interest in it. But back then, I did not know why
Yeah.
my ears were
We're
itching,
itching.
especially in the morning. I was like, oh
Yeah.
my gosh, what's happening?
And it's because of the decrease in the estrogen level.
Mhm.
It causes those delicate skin areas, such as the ear
My mother would say
canal.
somebody's gossiping about you.
Exactly, exactly. But it causes the ear canal to get irritated and itchy, and
Mhm.
so that's the role of the itchy ear, and the dry mucous membranes,
Right.
dry eyes.
So imagine if you're me and you're in your mid 40s and your ears start to itch in the morning and you've got vertigo and you have palpitations. Nobody thinks that the three of those things are related, your ear, your heart, and dizziness. And so I went on a cascade of medical workups and specialists. By the way, nothing was ever found and nobody ever told me you're probably perimenopausal. I had all of these negative workups. And let's talk about that because it's not just the physical impacts, it's the social and the mental. Here I am having all
Yeah.
of these real physical manifestations. I am seeing specialists. All of my workups are negative, and I'm just kind of being sent home with, I don't know, take an antidepressant. We didn't find anything wrong with you. Maybe it's in your
Yeah.
head. Take a vacation. You're probably stressed. You need to rest, which then puts further stress on me and on the individual because no one is putting it together and it makes it sound as if it's all in your head and something weird is happening to you and that maybe is not real because nobody in the
Yeah.
medical establishment can find it and that's unfair. So let's talk about what are the social and mental and emotional aspects of going through perimenopause and nobody's really explaining it to you.
So let's think about perimenopause and the time and the period of your lifespan that this occurs.
Uh-huh.
It's more common in your 40s. What else is
Mhm.
going on in your 40s? You've had children, they're growing up, activities, you're going in 10 different directions all at once, and you're being hit with brain fog, and
Right.
you're just not thinking as clearly, and your mood swings and irritability, and you're just stressed from daily activities. And all of that can be part of the social aspects of the perimenopause. Also, there's decreased intimacy with your partners,
Mhm.
and this affects your marriage.
Mhm.
And all of this can be attributed to the perimenopausal period. And we need to remember that when we treat a patient, we treat the whole patient, and we
Right.
treat the psychological aspects of that patient as well as the physical and the emotional aspects.
So
And
remember this when you are, and I'm talking to the audience, if you're anywhere from your late 30s to late 40s and early 50s and are having any kind of unusual symptoms, start to think about whether or not it could be perimenopausal. So, for instance, some people report weird taste in their mouth or a decreased ability to taste food. So all of these kinds of things, if these unusual symptoms begin to appear that you haven't had before, think about whether or not you could be in perimenopause. And that's the point of these webinars. We've got to begin to educate ourselves as well as the medical establishment with regard to what we need. I did not need the $1 million neurology cardiology workup. I needed just someone to understand that you're in your mid 40s, you're perimenopausal, you're not crazy. And so these are the kinds of things. That's why we're doing this. And because there really is a big social aspect when you're sent home, you know that you're having symptoms that are impacting you, like palpitations and dizziness. And yet everyone's telling you that there's nothing wrong with you. So you know that your shoulder is frozen. You know that you can't taste, your ears are itching, but no one's putting it all together. So that's what Dr. Reed is doing today. She's putting it all together for you, right? Arming you with that information. You're not crazy. You're not depressed. You're perimenopausal. And this is how we manage that. Let me ask you, is there any crossover between menopause, depression, aging? So often women are prescribed antidepressants at midlife. And it makes me wonder, are they really depressed or is everybody stressed that we're having all these changes and no one knows what's happening? And you have to live with this knowledge. So, what do you think about menopause, depression, aging? What's normal?
so if you really think about it and you look at what happens as a patient ages, you
Uh-huh.
start having decreased activity, decreased energy, fatigue, brain fog, lack of sleep. All of these things, do they not sound very similar to what I just said about perimenopause and menopause? And it is confusing sometimes to tease out what is exactly causing what,
Right.
whether this is part of the aging process, whether this is part of menopause, or whether it's a combination of all of the above. And it certainly can be. But,
Right.
and we will
Menopause certainly is a part of aging. It is,
right. And
right?
we will get into treatment options later in either this program or the next. But
Mhm.
the SSRI antidepressants can actually treat menopausal symptoms.
Mhm.
So sometimes we do use those medications in menopause, not only just for anxiety and depression, but to treat the symptoms of menopause as well.
And let's talk with the audience. What symptoms specifically do SSRIs? This is a type of antidepressant. She's describing a category of antidepressant medications. Is it the hot flashes? Is it the night sweats, which are the common symptoms that everyone knows about? But we're talking about the less common symptoms. But if you were to prescribe an SSRI antidepressant, what specific symptoms are you targeting for your patient?
I'm targeting the hot flashes, the night sweats, and the anxiety specifically that occurs with menopausal transition.
Mhm, mhm.
Those
So
are the
there is an
specific ones.
so,
And we do have patients who cannot take estrogen to
uh-huh,
replace, and this is a good option to treat those patients.
mhm. That's always good to know, and there are people who actually just maybe aren't interested in taking estrogen or doing any kind of hormone replacement therapy, would like to try other options. And as you said, if depression and anxiety maybe are a part of it, then this is perhaps effective in treating them both. And we'll talk about all of the treatment options probably in part two, but we're trying to level set today, make sure people even know what are we talking about. We're talking about perimenopause and
Absolutely.
menopause. So let's look now at menopause. we talked about the definition of perimenopause. We're just starting with the basics and making certain people understand what is the definition of menopause and how do you know when you are in menopause or when you are in perimenopause?
Okay. Menopause, by definition, is 12 consecutive months without a period. So,
Consecutive being the key word, guys. Consecutive. So if you go 3 months and then you have a period, you've got to start all over with your counting. Now
that's
that's been
correct.
interrupted. So it's got to be consecutive months.
So, and that truly is the only definition. Now,
Mhm,
symptoms that can occur are very similar to the same symptoms of the perimenopausal transition. And it's truly just a lack of the hormone that causes these symptoms. It's your hot flashes, night sweats, sleep issues, brain fog, anxiety, depression, arrhythmias, fast heartbeat can also occur during the menopausal transition.
mhm,
So, all of the same basic symptoms, but they can be more pronounced. And
mhm,
instead of your hormones waxing and waning during this period of time, your ovaries have pretty much stopped functioning hormonally from an estrogen point of view. We do believe that there is benefit of keeping the ovaries if you were to have a hysterectomy, and that they do remain active even after menopause,
mhm,
but not as far as the estrogen goes.
mhm, mhm. You know, as we age, the population ages, men, we've got these gender differences, and men get to be silver foxes and distinguished gentlemen. What do you deal with that with women coming in feeling that as they're aging and going through menopause, their value is actually diminishing? How do you manage that? So there's again that psychosocial and there's that gender difference of how we look at aging between men and women, and then this entire transition of menopause that's really poorly understood.
Well, with aging brings a lot of intuitive value.
Hmm.
You have a lot of life behind you, a lot of wisdom, and should never, ever downplay your importance in a relationship.
Hmm.
And just because you're aging doesn't mean that you have to give in to that.
Hmm.
Dieting, exercise, keeping your weight under control, which is an issue for perimenopause and menopause as well.
Oh,
Your
yeah, we
metabolism.
talk about that, gaining weight, that visceral fat around the middle, another common symptom. Thank you for bringing that up, Dr. Reed.
Yeah.
You guys are not
And
crazy. You really are gaining weight. It really is harder to take off. It really
yeah.
is harder to keep off. Yes.
And so we have to look at the diet and what's
Mhm,
better and what type of diet is better for patients as they go through the menopause for weight maintenance and to even decrease. So that those are important things. And I love yoga because you get the mind and the body.
mhm,
You
mhm,
get the joints and flexibility. And all of those are very important as we age, and for our vitality to remain active. And so, as far as having a silver fox, I would rather be the queen than the silver fox any
That's
day.
right, and as the queens, with all of that experience behind us, we actually enter in a period of our lives where we truly can, give to society and focus on ourselves, where we spent so much of our lives focused on others. Finally, all of the skills, all the experience, all the knowledge, all the education, you can pull it together to create something for yourself. It's a whole new era of your life, and instead of stepping back, you should step into it and embrace it and challenge the norms and be a part of that challenging of the norms. And certainly we feel misunderstood, especially if you're going to doctors with symptoms that are really impacting your life and your ability to work and your ability to be productive, and you're not getting answers. But that's why you're here with Dr. Reed today, to get those answers, to empower yourself. And most of all, when you leave today, you're not crazy, right?
Yeah.
So it's like perimenopause or menopause. So let's talk about this. Um, Hormone levels. And we don't necessarily have to get into treatments today because we've got part two
Right.
coming. But should people get their hormone levels checked? We get that question all the time. I'm having hot flashes, or I'm gaining weight, or I'm feeling as if I'm slowing down, or I have brain fog, or any number of symptoms. I think I might be in perimenopause or menopause. Should I get my hormone levels checked? And how do you
It tr
approach that?
Yeah, it truly depends on what the patient's symptoms are. Um, you have to remember that your hormones are only, as good as the day that they are checked.
Mhm.
And
And explain that. Explain, do you mean in a sort of the ovulation cycle or where? So maybe explain what that means.
so your hormones fluctuate during the perimenopause, and that's when most patients are going to come in and have that. I feel like I may be going through menopause
Mhm.
conversation with their physician. Um, a lot of times, a physician will not necessarily order labs the first time that you come in.
Mhm.
They'll take a good history, they'll listen to what you are saying to them,
Right.
and that will trigger in that physician's mind what is going on and where you are, depending on what your symptoms are. And
Mhm.
they may recommend monitoring, they may recommend treatment, they may recommend, uh, let me turn this off. They may recommend uh, getting hormone levels. But
Mhm.
most
Mhm.
of the time we don't, because we know that that hormone level is only as good as the time that it's drawn.
Right.
I will tell you that a patient that I would get hormones in
Mhm.
is someone that's older than the average patient and they're still having cycles.
Mhm.
I would want to make sure that their bleeding is truly menstrual. If
Uh-huh.
they're 56 years old and they're coming in and they're still having regular periods, I
Mhm.
want to make sure that that patient is still premenopausal.
Mhm.
And certainly the average age of menopause is 51 in the United States.
Mhm.
But there are people outside of those ranges, just like
Right.
you can start in menopause at 45, you can
Sure.
start through menopause at 55 or 6, or I've even had someone that was 59 years old and still having regular
Mhm.
periods. So, in that situation, the hormone levels would help us figure out where this patient is. But by and far, most patients we would treat depending on what they want to do,
Okay.
based on symptoms and not on hormone levels. If
Okay.
they're not responding to treatment, if they're still having symptoms after initiation of treatment, then it would benefit having the hormone levels checked.
So
But
you
routinely, no.
So you tend to check hormone levels when you are concerned about pathology or something abnormal going on. But a patient
Correct.
perhaps who's having perimenopausal or menopausal symptoms, who's in the right age range, you have more of a discussion with them and history and physical examination, and get an idea of what's happening, because the hormone levels don't necessarily guide therapy, because it's only a snapshot in time of where you are that Tuesday at 3:30 p.m., not where
Correct.
you were on Monday and where you'll be on Saturday. So we can only talk about this one snapshot in time, which makes it not as useful and as effective as a tool as you may think. And I know often people ask that, and that is why, because it's
Yeah.
only that snapshot in time. Um, and so sometimes it can be useful, and sometimes it would not be useful.
Correct.
Sometimes as well, and we might talk about this in part two, it might be useful if you are taking hormone replacement therapy, and we need to have some idea of where you are. If a patient comes in and just insists on doing their hormone levels, do you just do it, or do you talk them out of it, or how do you approach that with your patients when you're trying to have this conversation and also educate, because at the same time you're educating the patient?
Right. And that's what my answer is. I have the
Mhm.
conversation with the patient and I ask them, why
Right.
you feel like you need
Mhm.
to have this information. And the other question is, what are we going to do with the
Right.
information if we get it? Because if they're not interested, and there's a lot of patients who do not want to take hormones for
Mhm.
various reasons.
Mhm.
And if they're not interested in taking a hormonal replacement therapy, then why do we need to get
Right.
these labs?
Right. Right.
Just for academic
I think
reasons.
sometimes people think that's how you diagnose it.
Correct.
And so
And
how would you perimenopause is diagnosed by family history, age, symptoms. It's not necessarily diagnosed by a blood test. Would you agree with that, or what would you say?
no, absolutely, I agree with that.
See, I
And
think that's what patients think they're being diagnosed.
right. And they can be misdiagnosed by
Sure,
getting the blood test.
that's such a good point.
So because it can falsely be normal
Mhm.
and they're definitely having the symptoms. It depends on when you draw the blood. If you are going to draw blood in that perimenopausal or menopausal symptom or period of time, and you are still having periods, then the best time to draw the blood is right after your period starts, 2 or 3 days after you start your cycle.
Mhm.
Your hormone levels are going to be at their lowest point at that particular time. But if you have really irregular periods, then, it's not going to
Right,
benefit you. But if you're in that transitional stage and you're
right,
still having cycles, your hormones are going to be their lowest at that particular point in time. And that would be the best snapshot to
right.
see consistently what's going on if you insisted on having your labs drawn.
And you make another good point that I want to just reinforce with the audience. Irregular periods for 12 months does not mean you're in menopause. You have to go for an entire 12-month period with absolutely no periods, not no menstrual cycles, not irregularity. So I
Right.
just want to keep bringing that up because Dr. Reed keeps mentioning it. So I want to keep highlighting it so that we have this definition, because we're here to bring everybody up to speed, right? So we can learn, because we're going on to part two. So you
Yeah.
need to have a really good understanding of part one before we go to part two. Let me ask
So,
you, Dr.
I
Reed.
wanna say one more thing based
Sure.
on that, talking about having your cycle and when maybe when to call the doctor.
Mhm,
If you have transitioned through menopause and you have, by definition, had that 12-month with no period,
mhm.
and all of a sudden, 2 years after you've not had a cycle, you have some bleeding,
Right.
that needs to be evaluated,
That
and
does, and that is
that's
a
when you
risk factor for, sometimes cancer of your uterus or something, so that's called postmenopausal bleeding. So after
bleeding.
you've been through menopause, you should not have any further cycles, and if you do, you wanna see Dr. Reed or somebody immediately, to make certain. That's really a good point to make. That is really a good point to make. You touched on vaginal health about
Mhm,
menopause. So can you
mhm.
elaborate on what some of these symptoms are, and, what your patients may complain of when they come to see you? You talked about, dyspareunia or painful sex, the thinning of the skin, those types of things. Maybe you could just talk about that a little bit more. What is vaginal health? Incontinence and all of these things are happening.
So, I think everybody has heard of the term microbiome before.
Mhm.
As you transition through menopause, your pH changes in the vagina. And it can cause your normal bacteria that live in the vagina to change.
Mhm.
And because you do have decreased estrogen to these tissues, the vagina also has receptors to estrogen. And the lack of estrogen causes the vagina to have dryness,
Mhm.
irritation because of the dryness. The actual thickness of the skin of the vagina decreases. So, painful intercourse is usually caused by that friction from intercourse. And you can have a odorous discharge from menopause that is technically normal, but it's
Mhm.
caused because if you think about something with a real thin film over it, it can weep. And your vaginal mucosa is like that when you go through menopause. It gets so thin, it can weep, and that causes that discharge.
That is such a
Um,
good description. Mhm.
yeah. And so one of the some of the things that we recommend, vaginal moisturizers, you can get them over the counter, KY jelly, Replens, there's others. One of the best vaginal moisturizers is actually coconut oil.
Mm.
And you can get a some of those designer ice trays that are tiny little squares. Uh,
Mhm.
put your coconut oil in it, put it in the freezer, and it actually makes like a little suppository. And
Mm.
it's safe to just put that in the vagina at bedtime, and you get that vaginal lubrication there. There are other lubricants. Some are Astroglide, and they have a more mucus type feel to them,
Mhm.
so that it will decrease the friction with intercourse and decrease that pain.
Okay, so
Obviously,
you're talking about utilizing these in order to decrease the pain of sex when you're having sex. Um, is that
and
you also
dryness.
use them when you're not having sex
Yeah,
just to keep the vagina healthy? What about
they're
things like
they're
hyaluronic acid and
mhm.
these well, just tell me what you would recommend. Let's talk with our audience, what you would do.
So yeah, there are some products that are available over the internet, and
Mhm,
they're hyaluronic acid based. They help to rebuild the collagen of the skin of the vagina, which helps to increase that elasticity. There's two that are on the market under the brand name of Reverie and
mhm,
Halogyne, and you can look them up on the internet and order it, and you just use it as directed as a treatment for the
mhm,
collagen
mhm.
replacement. Just like you put hyaluronic acid formulas on your face. Well, what's good for your face is good for
Well,
your
that might
vagina
be news to some of the people in the audience as well. Maybe they're not putting hyaluronic acid on their face.
on their face. Yeah. But that it just helps with the integrity of the skin, and
Right,
definitely that is an option. And estrogen cream is an option, just using a very low dose. There's also other medications that specifically treat the vagina, and one of those is osmafene.
mhm,
It's a prescription medication
mhm,
as well as intrarosa. And both of these are non-estrogen. Osmafene is a designer estrogen. It only has receptors for the vagina.
mhm,
So if you had, although there were not studies done in breast cancer patients, technically, it should not affect the breast tissue because
mhm.
it's a different estrogen receptor. And
Right,
then the DHEA is the intrarosa, and that's a suppository that helps with vaginal dryness as well to treat it, not just to moisturize it. These are
right.
actual treatments.
Those are all good suggestions. You if you are experiencing these symptoms, perimenopause, menopause, how is it best to work with your primary care doctor, even other physicians who may actually not be armed with the information and may misdiagnose you or dismiss you, as I was, as happened to me, and I'm a physician. How do you work with your doctors, or do you change doctors, or do you look for someone specifically who's menopause certified? What would you recommend as women are trying to have these conversations with maybe a medical establishment that's not yet trained to have them?
Right. You know, in 2002, the WH study came out on women's health and hormonal replacement.
So
And it
that's
was
the
a
Women's
study
Health Initiative study, I'm
initiative.
just telling the
Yeah.
audience. WHI is the Women's Health Initiative.
And it became a media sensation overnight. Physicians, primary care physicians, some OBGYNs as well. Everybody was just taken off of their hormones immediately based on the study. 20 years later, we've done a lot of dissection of that study, and we have found that hormonal replacement therapy is safe in certain patients, and everybody is individualized. It depends on your risks, and there are definitely risks that patients carry that they should not be on estrogen. But for the average menopausal patient who does not have contraindications for it, hormonal replacement therapy started at the menopause is very safe. And when you look at all-cause mortality in this group between 50 and 60, when the patients were started on hormones or compared to patients who never took the hormones, the all-cause mortality is decreased in that age group who took the hormones versus the age group that did not. So we have learned a lot. We have had a lot of women over the last 20 years suffering um, as they transitioned through menopause without estrogen. And I think that's our message today is it's important to have these conversations. And if your primary care physician is not aware of treatment and options, then certainly ask to be referred to a gynecologist or a menopausal specialist in your area who can have that conversation with you and explain the risks versus the benefits of the various therapies. And not all of them are hormonal. So there are options available, and it's important for you to have that conversation and start with your primary care physician. And if they're not familiar with treating, then ask to be referred to someone who is knowledgeable in the treatment of menopause and perimenopause.
Dr. Reed, such a pleasure to have you with us today. I learned a lot. I hope everybody in the audience learned a lot. Come back for part two because, as you know, I'm a cardiologist and we will be talking about different therapies, including hormone replacement therapy, which means estrogen, progesterone, and in some cases, testosterone, and what those effects are on the heart. We didn't talk about heart symptoms and your risk of heart disease as you go through menopause. So, we've got a lot to talk about in this series. So today we level set. We hope you got a lot of information. Come back for part two. Each time we come back, it'll be more and more information that we're adding to help you live your best life, your healthiest life, your strongest life. This is the best time of your life, and we want to help you live it. So again, thank you, Dr. Reed. This is Dr. Jayne Morgan. I am here with the Medical Association of Atlanta with our part one webinar on menopause. We'll see you next time.